Hello everyone, welcome back to Comment Made Easy, and I hope you all are doing very well. Before we begin, let me remind my dear students that the contents of this channel are only to supplement your knowledge, not to replace the regular online and offline classes in your institution. So please attend your classes and do not miss them. Also, if you like our contents, please subscribe to our YouTube channel, like the videos, and share these videos with your friends, with your batchmates, with your juniors. Also, if you are a teacher, then with your students. Please follow our Facebook page, and the link will be given in the description. Today's topic of discussion is rabies. In our country, we have so many stray and pet animals, for example, cats and dogs. So that is why a person being bitten by a dog or cat or even scratched by them is quite common. We get a lot of cases where a person come to us with complaint of being bitten or scratched by their pet animals or any stray animal. And that is exactly why you have so many cases of rabies as well as so many deaths from rabies in our country. Rabies is an acute viral disease of central nervous system that affects almost all warm-blooded animals, including human population, and it causes fatal encephalomyelitis. This is invariably a fatal disease. That means a person suffering from rabies will die because there is no cure available, and this disease causes hydrophobia, that is fear of water, and aerophobia, that is fear of air. And even though there is no cure available, but this disease is actually highly preventable if we use the immunization, that is anti-rabies vaccine or even immunoglobulin at the correct time. There are some countries which have achieved rabies-free status. Now, what do you mean by a rabies-free country or rabies-free area? So, a rabies-free area is that area where no indigenous acquired rabies cases have been reported either in the human population or in the animal population in previous 2 years. Now, most of the death from rabies that occurs every year is reported from the rural areas of the two continents, that is Africa and Asia. India alone contributes about 20,000 deaths every year. Also, India contributes 36% of the global and 65% of the Asian human rabies death. Coming to the agent factor, so this is Lissa virus type 1, because we also have type 2, 3, 4, etc., but they do not cause rabies. Lissa virus type 1 causes rabies. The family is Rhabdoviridae. It is a bullet-shaped, single-stranded RNA virus and is neurotropic. That means it has affinity towards the central nervous system tissue. So as you can see, this is the cross-section of the virus and they look like bullets. Now, there are two kinds of rabies virus. One is street virus, another is fixed virus. Street virus is recovered from the natural occurring cases of rabies. So that means if a person or even if an animal is suffering from rabies, we can get the street virus from that victim or the case. It is a naturally occurring virus and it is found in the saliva of the infected animal. It produces what is known as Negri bodies, and we shall discuss it later. It has long incubation period, about 20 to 16 days. Some authors or some books also mentions it is as long as 90 days. This is the raw and naturally occurring virus, and this is not used for vaccine preparation. On the other hand, when street virus is passed serially from brain to brain and after repeated culture, it will produce what is known as fixed virus. Now, fixed virus has short incubation period which is reproducible, and this incubation period is about 4 to 6 days. It does not produce Negri bodies, but fixed virus is used for vaccine preparation. So this is the difference between the street virus and the fixed virus. The source of infection are in our country mostly dogs and cats, but wildlife like fox, jackal, and also sometimes very rarely vampire bats can be sources of infection. So these are the different animals transmitting rabies in India. Among the domestic, that is pets, dogs and cats. Peri-domestic, that means which are available or present around our houses, in our locality, etc., like cows and buffaloes, sheep and goats. You can see this is a picture of the rabbit goat, pigs, donkeys, horses, camels, etc. In wild or forest, fox and jackals, monkeys, mongoose, bears. Not reported as in India, bats, rodents, birds, squirrel. These are very uncommon. Now regarding rodents, let me mention something, because this is a very commonly asked question, or rather inquiry from your relatives or even from your neighbors. They will say that I have been bitten by a mouse or rat in my house. So do I need to take anti-rabies vaccine? The thing is, it is the field mouse that is reported to have association with rabies. The domestic or the house rat or house mouse are not associated. So that is why if a person is bitten or even scratched by a domestic mouse or rat, the person ideally do not need to take anti-rabies vaccine. He can be assured if there is a cut injury, he can take tetanus toxoid, but otherwise it is not needed. The anti-rabies vaccine is not needed. Okay, what about the host factors? As I already mentioned, all warm-blooded animals, including men, are susceptible. But there are some high-risk population that includes the laboratory staff working with rabies virus, veterinarians, dog handlers, hunters, field naturalists, etc. So that is why, because since these people are more exposed to the animals which are associated with rabies, so that is why they are considered to be high-risk population. Mode of transmission is either by deep bite or scratch by an infected animal, licks on abraded skin or mucosa, and rarely, very rarely, by inhalation of virus containing aerosol, which may be present in few laboratories, organ transplantation, and human bite. These are very uncommon. Incubation period is about 1 to 3 months, but may be as short as 7 days and can be as long as many years. Now, since the incubation period is of varying duration, we can say there are a lot of factors it depends on. For example, the site of the bite. The further in our body the bite is, for example, lower limbs, legs, etc., the longer is the incubation period. If it bites closer to our central nervous system, especially the brain, for example in the neck, in the face, the incubation period is shorter. Severity of the bite, number of wounds, amount of virus injected, and species of the biting animal. Protection provided by the clothing and treatment undertaken, if any. So all these things actually influence the duration of the incubation period. What is the pathogenesis? So virus replicates in the muscles or connective tissue cells at or near the site of biting or injury. So after being bitten, the virus multiplies in the connective tissue or muscle cell near the site where the bite or the injury has taken place. Then this virus attach themselves to the nerve ending and enters the peripheral nervous system. Then it ascends centripetally, as in towards the center, to the central nervous system, infects the central nervous system, and then spreads centrifugally, as in outward, through different peripheral nerves, and is spread to different tissues like skeletal or myocardial muscles, adrenal glands, skin, and salivary glands. Now, for a person to be infected to others, the person, for especially dogs and cats, the salivary glands should be infected, because whenever this animal will bite another person or another animal, if the salivary gland is infected, that means there is high probability of transmission of the virus to this new susceptible animal or human being. So this is the same thing. As you can see, virus enters tissue from the saliva of the biting animal here. The virus replicates the muscle in the muscle near the bite. Virus moves up peripheral nervous system to the CNS. Here it reaches CNS, and after that it infects CNS, and then it enters salivary gland or outer organ of victim, because from the CNS it takes the route of a peripheral nerve and reaches to different muscles, organs, glands, etc. Coming to the clinical features, the disease starts with prodromal symptoms which last for only 3 to 4 days, and there are some non-specific symptoms like headache, malaise, sore throat, even mild fever. This prodromal stage is followed by widespread excitation and stimulation of the nervous system. Different systems are affected in order. That means first the sensory system is affected, then the motor system, then the sympathetic, and then the mental system or the mental condition. So first the sensory system is involved and the patient is intolerant to noise, bright light and cold draught of air. Aerophobia is developed. Aerophobia means fear of air, and it is considered to be pathognomonic of rabies. Next, motor involvement is expressed as increased reflexes and increased muscle spasms. This is followed by sympathetic system involvement. There is dilatation of the pupil, increased perspiration, salivation and lacrimation. Then the mental condition is affected. There is fear of death, anger, irritability, depression in the patient. With progression of the disease, all attempts at swallowing liquid becomes unsuccessful. So the person cannot swallow liquid, that is water. So at later stage, the mere sight or sound of water may provoke spasm of the muscles of deglutition. So even if the person looks at the water or even he hears the sound of water, running water, his muscles of deglutition will spasm or contract, and that will make it difficult or even impossible for the person to swallow any fluid. So aerophobia or hydrophobia, these two are obviously different, may develop, which are involuntary painful contraction of the diaphragm or accessory respiratory, pharyngeal and laryngeal muscles in the response to exposure of draft of air, so that is aerophobia, or sound or sight of water, that is hydrophobia. Diagnosis is done clinically by history of bite of a rabid animal or characteristic signs and symptoms. But this diagnosis can be confirmed by antigen detection using immunofluorescence of skin biopsy and by virus isolation from the saliva and other secretions. So earlier I talked about Negri bodies, which is produced by the street virus. So they are cytoplasmic eosinophilic inclusion bodies in neurons that are composed of rabies virus proteins and RNA. So in this diagram you can see this is the Negri body. The arrow mark is showing the Negri body here. They are most common in the hippocampal pyramidal cells, cerebellar Purkinje cells and brainstem nuclei. Coming to the treatment, we already mentioned that there is no specific treatment or specific cure for rabies, but if we ever come across a patient suffering from rabies, then the management includes isolation of the patient from all possible stimuli, relieving the anxiety and pain of the person, application of antispasmodics with curare-like action, ensuring hydration and diuresis, and also providing respiratory and cardiac support. Now prevention, the principles of prevention include observation of animals for a particular time, categorization of the wound, local treatment of the wound, vaccination, that is post-exposure prophylaxis, and also application of immunoglobulin if needed. First one is observation of the animals. It is applicable for the dogs and cats only. We may have to observe the animal for say 10 days from the incidence of biting or scratching, and after that we can modify post exposure prophylaxis accordingly. That means if say after 10 days there is no change in status, health status or even mental status of the dogs or animal which have bitten or scratched, then in that case we can discontinue the post exposure prophylaxis. So we must start the post exposure prophylaxis or any other necessary treatment from day one and then continue observing the animal. It is not like we will observe the animal for 10 days and only after that we will start the PEP. It's not like that. We have to start from day one itself and then we have to observe the animal. Next is categorization of wound, which is very important because based on the category of the wound, the approach for post-exposure prophylaxis may change. So in category 1 we have three categories, category 1, 2 and 3. In category 1 there is only touching or feeding an animal, leaks on intact skin, so there is no breakage of the skin, there is no ulcer or cut injury, and maybe the animal leaked on it. So in either cases, since there is no injury on the body, so that is why no treatment is required. So that is post exposure prophylaxis is none, so nothing is required here. In category 2 there is nibbling of uncovered skin. So what happens, sometimes domestic cats or kittens or even puppies bite on our fingers, hands, etc., but it's only nibbling, that means very mild small bites without causing any breakage of the skin, there is no bleeding, etc. So if there is nibbling of uncovered skin or even minor scratches or abrasions where there is no bleeding, we have to look for that, it is very important. So if there is a scratch mark or abrasion, we must ask the person, the victim, whether there was any bleeding. If there is no bleeding, then also it is considered to be category 2. In category 2, of course, since there are some kind of abrasion or scratches, etc., etc., there is need of local treatment of wound, and this should be followed by immediate vaccination, that means initiation of post exposure prophylaxis. The category 3 injury includes single or multiple transdermal bites or scratches. So here the bite or scratches, especially the bites are not nibbling, here the bites and scratches are deep and they are transdermal and probably there is bleeding. There can be leaks on broken skin, that means probably there was already an ulcer or cut injury, and on that or near to that maybe a pet animal or whatever, it leaked. Contamination of mucous membrane with saliva from the licks or contacts with bats, this is also very common. In any case, all these conditions are considered to be category 3. In category 3, of course, we have to do the local treatment of the wound. This should be followed by immediate vaccination, that is initiation of post exposure prophylaxis. So this point 1 and point 3 are same as category 2. Here in category 3 there is need of administration of rabies immunoglobulin. So that is why we must understand which category this particular injury belong to. If it is category 1, nothing is needed. If it is category 2, then local treatment of wound with PEP. Category 3, same thing, local treatment of wound with PEP, but also we have to give the immunoglobulin. So local treatment of wound, which is important. So what are the do's and don'ts? So we have to wash the wound under running tap for at least 15 minutes. Soaps can be used, antiseptics can be used, but remember, when we are talking about soaps, detergent soaps used for cleaning or washing the clothes or utensils should not be used, okay, because these detergent soaps are alkaline in nature. Alkaline, they are actually hygroscopic, and they also damage the tissue even more. So more tissue damage means more chance of having the virus getting penetrated into our system or into our body. So that is why detergent soaps should be avoided. Suturing, whether a cut wound should be sutured or not. Ideally, suturing should not be given. If the wound is gaping, that means it is wide and there is deep wound, then only after giving the rabies immunoglobulin, that is RIG, we can give 1 or 2 suture just to oppose the gaping wound. So that means otherwise suturing is contraindicated. Suturing should not be done, because whenever we are giving suturing with the needle, where we can actually penetrate into deeper tissue, and we can make the virus or help the virus to get into the deeper tissues and then attach themselves to the nerve ending. So that is why, to avoid deeper penetration of the virus, we should avoid suturing, but only if the wound is a gaping wound or a very deep wound. In that case, maybe we have to give 1 or 2 suture, but only after giving rabies immunoglobulin. So what are the don'ts? Any indigenous methods or concepts should be discouraged. For example, soil, chili, turmeric powder, oil, plant juices should not be applied on the wound. No need to cauterize, and again suturing should not be done unless it is absolutely indicated. So these are the do's and don'ts, and this is how we do the local treatment of wound. It should be done immediately. This is followed by vaccination, that is post exposure prophylaxis, also known as PEP. Now there are multiple regimen. This is done by anti-rabies vaccine. We have intramuscular regimen as well as intradermal regimen. In intramuscular there is Essen regimen and Zagreb regimen, and intradermal we have updated Thai Red Cross regimen. Now mind it, in the book of Park the alternate intramuscular regimen is mentioned as Zagreb regimen, Z-A-R-E-B, but it is a typing mistake, and for some reason it has been continued for editions after editions. They have not corrected it. It is actually Zagreb regimen with a G in between Za and Reb. Anyway, so what are the different type of rabies vaccines? The different types are cell culture vaccines or CCV, embryonated egg vaccines or EEV, and nerve tissue vaccines, that is NTV. NTV, for example, simple vaccine, they are outdated and are not used anymore. The cell culture vaccines include human diploid cell vaccine like HDCV, purified chick embryo cell vaccine like PCECV, purified varicocele rabies vaccines PVRB, and primary hamster kidney cell vaccine, that is PHKCV. Embryonated egg-based vaccine include the purified duck embryo vaccine PDEV. So these are some of the commonly available product in our country. So we have here Rabipur, which is PCEC. PCEC stand for purified chick embryo cells, right? Avoirab, this is purified varicocele rabies vaccine. We have Velorab, which is again a varicocele vaccine, and also we have rabies vaccine, that is Indirab, which is prepared on varicose. It is written here. So as you can see, most of the products are of cell culture type. Alright, now coming to the individual regimen. First we have the intramuscular regimen, the Essen regimen. In Essen regimen, the person is given intramuscular injection of the vaccine on 5 different days. So that is why the person has to visit 5 times, and each time one vial will be opened for the vaccine, so 5 vials will be used. So the dose is given either 0.5 ml or 1 ml based on the type of the vaccine, because it varies from different company to company. So the doses are given on day 0, day 3, day 7, 14 and 28. So this is the Essen regimen, 5 doses intramuscularly given. Then there is Zagreb intramuscular regimen, where the person has to visit 3 times. So 3 visits on day 0, 7 and 21. Remember this. Now on day 0, that is the first visit, the person will receive 2 injections. Okay, so 2 intramuscular injections at 2 different sites, preferably at the insertion of the deltoid on either side. 2 injections are given. On day 7 only 1 injection, and on day 21 another injection. So 2 plus 1 plus 1. So 4 injections the person will receive on 3 visits. Since 4 injections are being received, so there will be need of 4 vials. So 4 vials, 3 visits. This is Zagreb intramuscular regimen. Now we have the intradermal regimen, that is the updated Thai Red Cross or TRC regimen. Now this is the recommended one, because in national program we are actually recommending people to use the, or doctors or healthcare professionals to use the intradermal regimen. So again, for intradermal regimen, the person has to visit on 4 different days, that is day 0, 3, 7 and 28, and on each day the person will receive 2 injections. So total 8 injections or 8 doses are needed on 4 different visits. Now the thing is, the dose for individual injection, intradermal injection, is fraction of the intramuscular dose. So that is why if we calculate or consider all the doses together, then even 2 vials are not used. So the content of 2 vial is more than enough to give 8 different intradermal injections. So this is also very important. So remember that we need fraction of intramuscular dose for intradermal route. And in intradermal regimen, the person visits on 4 different days, and on each day he receives 2 intradermal injections. So total 8 doses on 4 different days. So this is updated thyroid first regimen. Next is the Rabies immunoglobulin or RIG. This immunoglobulin is given in all category 3 injuries, and we discussed this earlier. Immunoglobulin is administered only once. It has to be administered on day 0 when the person is receiving the first dose of his post-exposure prophylaxis or PEP vaccine. So as you can see, whatever be the regimen, it can be intramuscular regimen or intradermal regimen, the person will receive the immunoglobulin on day 0 only. So there is no need to give or administer immunoglobulin on multiple occasions, only once. If for any reason the immunoglobulin could not be given within 7 days after the injury, and 7 days have passed since then there is no need to give immunoglobulin. So what happens, sometimes the person will report after 7 days of being bitten or scratched, or maybe for any reason, maybe because of unavailability of the immunoglobulin or whatever, immunoglobulin could not be given within 7 days following the exposure. So in that case, if 7 days have passed, then there is no need to give immunoglobulin. We have the equine immunoglobulin prepared from horse's serum, and also have human immunoglobulin. The dose is 40 international unit per kg body weight for the equine variety, and 20 international unit per kg body weight for the human variety. Of course, human variety or human immunoglobulin is preferred over the equine immunoglobulin because it has less side effects. That means there is less chance of anaphylaxis or allergic reaction, etc. Immunoglobulin, which is to be administered, is infiltrated as much as possible. So the quantity should be as much as possible in the depth and around the wound. So wherever is the wound marks, like the bite marks or the scratch marks, it should be infiltrated in the wounds and around the wounds. After infiltration, if any amount is left, so this leftover immunoglobulin is to be injected intramuscularly at a site distant from the site of post-exposure prophylaxis vaccination. So whatever, say the person received the vaccine in the left upper arm at the insertion of the deltoid, just above the insertion of the deltoid. In that case, the person should receive the immunoglobulin, if any leftover is there, either in the right upper arm or maybe in the lower limbs, maybe in the lateral aspect of thigh or in the buttocks, whatever. But always remember, immunoglobulin is given intramuscularly. It is not given intravenously. This is very important. Next is pre-exposure prophylaxis. So there are some people belonging to high risk population who are at higher risk of getting exposure. So who are these people? They are the laboratory staff handlers who handle the rabies virus and infective material, clinicians and persons attending the human rabies cases, veterinarians, animal handlers and catchers, wildlife wardens, quarantine officers, travelers from rabies free areas to rabies endemic areas. So since these people belong to the high risk population and they are at higher risk of exposure, they need the pre-exposure prophylaxis, also known as PrEP, PrEP. So it can be given intramuscularly or intradermally. Intramuscular dose is 0.5 ml or 1 ml depending on the type of the vaccine. If it is intradermally given, then the dose is 0.1 ml. Site is deltoid, as in just above the insertion of deltoid, and it is given on 3 days, day 0, day 7, and then either day 21 or day 28. So the person has to visit on 3 different days and will receive 3 doses of the vaccine, either intramuscularly or intradermally. Now coming to a very important part, that is post-exposure prophylaxis in a previously vaccinated person, that is re-exposure. So let me give you a real life situation. Suppose a person comes to you and tells you that, doctor, I have been scratched by my pet dog yesterday. Do I have to take any vaccine? You will tell him, since you have been scratched, of course you have to take the vaccine. Then he will tell you, doctor, he is my pet dog and I was bitten by him about 3 months back, and then I also took the full course of vaccine. So considering this situation, tell me whether I need to take the vaccine again for the current injury, and if I have to take, then whether I have to take all the injections or not. So that means based on the history of previous vaccination, our answer or our response may change. So it says re-exposure after a full course of either post-exposure prophylaxis or pre-exposure prophylaxis, intramuscular or intradermal regimen with CCEV. So what does it mean? First of all, it has to be a full course. That means the previous vaccination must be full course. So he must have received all the injections during his previous vaccination. It could be a PEP, that is post-exposure prophylaxis. So maybe he was bitten or scratched by his dog. So that is why he would receive post-exposure prophylaxis. Or maybe he is from high-risk population group. So that is why he had to take pre-exposure prophylaxis. So in either cases, does not matter whether it was an intramuscular or intradermal regimen, but this is important, the vaccine that he should receive should be of CCEV. That means it should be either of cell cultured vaccine or must be a embryonated egg based vaccine, either of these two. We read the classification earlier, if you remember. So in if all these criteria are fulfilled, then irrespective of the category of the exposure, that means whether this current injury, it could be category 2 or category 3, does not matter. Category 1, we do not need to do anything, we know that. And also time since the previous vaccination, again does not matter how long back he received the previous vaccination. So if all these criteria are fulfilled, then for this current exposure or current injury, he only needs 2 booster doses, that is on day 0 and day 3. And also rabies immunoglobulin is not needed. So let me repeat again, the person must have taken either PEP or PrEP, whatever, could be intramuscular or intradermal regimen, but it had to be full course. That means all the doses were received and the vaccines were either cell cultured vaccine or embryonated egg based vaccine. So in that case, for the current injury, the person will require only 2 booster doses on day 0 and day 3, and immunoglobulin is not indicated. In any other situation, for example, if the previous vaccination was incomplete or partial, that means the person did not receive all the injections, in that case the current injury, it should be considered as a fresh case and the person should receive all the doses for this current or the present injury. Also re-exposure following PEP with NTV. So if you remember, along with cell culture vaccine and embryonated egg vaccine, we also have nerve tissue vaccines which are outdated. So if the previous vaccination was with nerve tissue vaccine, then for the current injury the person actually needs the full course of vaccination. The 2 doses or 2 booster doses on day 0 and day 3 are not adequate in that case. Alright, so these are the different criteria. Now if you notice carefully, I have written this statement, time since previous vaccination, in italics, because this statement needs some explanation. Suppose I say that I received the previous vaccine about 10 or 15 years back. So that means it has been 10 or 15 years since I received the vaccine. So does it mean if I am exposed again today, only 2 doses or booster doses on day 0 and day 3 will be adequate, even though my previous vaccination was 15 years back or 10 years back? So that means there must be some time period beyond which 2 doses or booster doses will not be adequate, right? So let me give the explanation. According to few guidelines, re-exposure following a complete course of vaccination in last 3 months requires only 2 doses. that is on day 0 and day 3. So what does it mean? It means if the person is exposed again, we have to ask him whether he received the vaccine in last 3 months or not. If the last vaccination was within 3 months, then the person will need only 2 doses, that is day 0 and day 3 booster doses. But if the previous vaccination was more than 3 months ago, that means maybe 3.5 months, 4 months, 1 year, 2 year, 10 year, doesn't matter. So in that case, the person will require full course of vaccination. So that is why we say the cutoff mark of 3 months. But again, according to many, this concept of 3 months is not very logical, because the question is, where do we get this 3 months from? It could be 2 months, it could be 4 months, 6 months, 1 year. So this 3 month is questionable. The concept is, following a full course of vaccine, we should have adequate titer of neutralizing antibody in our system, so that whenever we are re-exposed, this antibody can actually protect us from the disease. If the antibody titer goes down beyond a certain level, then we will have to take the full course of vaccine. So guideline says if the neutralizing antibody titer is more than 0.5 international unit per ml, it is considered to be adequate, and the person will require only 2 doses on day 0 and day 3. If the antibody titer is less than 0.5, then the full course of vaccination is required. So that means if a person comes to you and tells you that I have been scratched or bitten, do I need vaccine? But also he tells you that I received the vaccine about 3 months or 4 months or maybe 1 year back. Best thing is, for this re-exposure, you tell the person to do a neutralizing antibody titer test. So if the value is 0.5 and above, then tell the person that he needs only booster doses on day 0 and day 3. If the antibody titer is less than 0.5, tell him that the person will need the full course of vaccination for this current exposure. Alright, so with this we conclude rabies. If you like our video, please subscribe to our channel and share this video with your batchmates, with your juniors, and with your friends from other colleges also. You also have our Facebook page. The link is given in the description. You can follow our Facebook page also. Thank you, take care, and we shall see you in our next video.